Hi everyone. So good evening. We meet again this week, and this time we'll be discussing the next biological which we use routinely to treat chronic plaque psoriasis. This time we'll be discussing infliximab. So infliximab is again a TNF alpha inhibitor. Okay, or you could just say that it's a biological which is supposed to counteract the effect of TNF alpha. If you want to know that how does TNF alpha leads to the progression of psoriasis, I would request you to go back and see the video on pathomechanism of psoriasis, and everything will be a bit clearer to you. And gradually over the next few weeks, we will traverse all those cytokines and chemokines to see what all inhibitors are available for us to be used in psoriasis. Clear? So we'll be discussing infliximab today, and most of the you could say mechanism of action, side effects, monitoring guidelines, all of them are somewhat overlapping with adalimumab. So go back and see that video on adalimumab, and you'll be able to easily find a lot of similarities between infliximab and adalimumab, and it will be much more. It will be much easier for you to understand all of these different TNF alpha inhibitors and what makes one TNF alpha inhibitor different from other inhibitors, and in what specific situations you'll be able to use one inhibitor over the other. So it will help you to have a good grasp about TNF alpha inhibitors, particularly infliximab, after today's presentation. Okay, so with that, we'll start our discussion on infliximab in dermatology. Now, it's a chimeric Ig1 monoclonal antibody which targets tumor necrosis factor alpha. Now, this word is important. What is chimeric? Now, infliximab. If you all people want it, we can have a very short video on naming of biologicals, so you'll be able to understand much better regarding their individual side effects and properties. If a biological has XI in their name, XI, so it is chimeric. And what do we mean by chimeric? Chimeric means that some part of infliximab will be derived from human cells or from human genetic code, while some part will be derived from some other species. So in case of infliximab, it is 25% derived from the mouse genome, 75% from human genetic material. Okay. So if you remember the structure of immunoglobulins, so you have a constant region which is known as FC, and then you have a variable region known as FAB. If you just recall immunology, this is the variable part which changes as per the requirement of attachment of different type of antigenic molecules. Okay, so this part or a portion of this part is derived from murine or from mouse. Murine means mouse. So 25% of infliximab molecule is derived from mouse genetic material, while the rest 75% is from human, and that makes it chimeric. And one important property of chimeric immunoglobulin is that it will lead to formation of a lot of autoantibodies. Now, what are autoantibodies? Whenever we introduce any kind of protein structure in the human body, in the human system, the immunity will recognize that as foreign molecule and will react to it. Now remember, in adalimumab, that's a fully human monoclonal antibody, and because of that, the autoantibody generation is not that much. But in infliximab, since it has 1/4 of the molecule derived from mouse, it will lead to significant development of autoantibodies, and subsequent exposure to infliximab may lead to decrease in its efficacy because of this particular property of infliximab. And those autoantibodies will neutralize infliximab, and gradually you will see that the drug you are giving is now showing a bit less efficacy as it was showing previously. Okay, so remember, because of this murine molecule, a lot of autoantibodies are formed. Clear? So it's a chimeric Ig1 monoclonal antibody against human necrosis factor. 25% of it comes from mouse, 75% is the human IgG molecule. In 1998, it got approved for Crohn's disease, and subsequently it received a lot of approval for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, both in adults and pediatric population. For us, for dermatologists, it has been approved by the FDA for use in moderate to severe plaque psoriasis and psoriatic arthritis. Okay. Now, infliximab is an IV infusion. Remember that adalimumab is subcutaneous. So, infliximab is an IV infusion. That means over the course of 2 to 3 hours, this infusion is administered. If a drug is IV administered, that means hospitalization is necessary, and you may not be able to give this drug in an OPD basis. You might have to hospitalize, pre-medicate, and monitor the patient for the single infusion. Okay, let's move forward. The bioavailability is 92%. In some of the book, it is mentioned as 100% since this drug is given IV, but there are multiple issues regarding the molecule and the efficacy of that. And since a lot of time we are using biosimilars, not even biologicals, so the bioavailability which is mentioned in literature is 92%. Okay, it has high affinity and selectivity for TNF alpha only. Now remember that there are two different kinds of TNF alpha. TNF basically, you have TNF alpha and then you have TNF beta. And TNF beta is also known as lymphotoxin. Okay, and many of the TNF alpha inhibitors also block TNF beta, but infliximab does not. Infliximab has high selectivity for TNF alpha only. Okay, so TNF alpha only. And remember in the video on adalimumab and psoriasis, we said that TNF alpha are two types. One is soluble, other is membrane bound. The activity of infliximab is more on the soluble TNF alpha. The membrane bound, there is some activity, but that activity is clinically not much significant. That means it won't lead to much improvement in the disease. Major improvement is seen via its sequestration or controlling the soluble TNF alpha or binding the soluble TNF alpha, and thus you don't have that downstream effects. Now, T half of infliximab is 7 days if the dose is 3 mg per kg. Some books mention as 9 days when the dose is 5 mg per kg. Okay, so both of these are correct. A good answer will be 7 to 9 days. Some books mention 8.3. They're getting too specific. The T half is 7 days, as mentioned in a lot of literature. If the dose is increased, it tends to stay longer, and the range is 7 to 9 days. Now, it is metabolized by proteolysis. See, remember that immunoglobulins are essentially protein molecules. They are made up of amino acids. So they will get degraded as the normal immunoglobulin in our body gets degraded. So degradation by proteolysis, and it gets broken down into non-specifically different proteins and different amino acids. That's how it gets disintegrated and then gets excreted via two mechanisms. One is through urine. Okay, one is through urine and through bile. So all these degraded products get excreted through bile or urine. Clear? Now, infliximab binds to TNF alpha, and remember this is majorly the soluble part, and then prevents its attachment. So remember in adalimumab we were saying that let's say this is TNF alpha receptor, okay, and let's say that this is TNF alpha in green. So what infliximab does is infliximab binds to the soluble TNF alpha and prevents its attachment to its receptor. So this attachment does not take place, and when this attachment doesn't take place, TNF alpha does not attach to its receptor. There are no downstream effects, majorly through NFK beta, and there is no translation of inflammatory cytokines. Okay, so remember how TNF alpha acts. TNF alpha leads to a lot of inflammatory cytokines, translation of multiple inflammatory cytokines, and that does not happen because it has been blocked by infliximab, and it is not being attached to its receptor. Clear? Now, subsequently, attachment and blocking of TNF alpha leads to decreased inflammatory cytokines and also decreased migration of inflammatory cells. If you want to know how TNF alpha acts in psoriasis, just look at the psoriasis pathomechanism video first. And if you want to know how does the blockage of TNF alpha leads to the therapeutic effect of TNF alpha inhibitors, just we'll revise a bit in this presentation, but it's a good idea to go back and see the Adalimumab presentation. We have discussed that in detail there. So there's decreased inflammatory cytokines, there's decreased migration inflammatory cells. Also, matrix metalloproteinase is responsible for fibrosis. The increased CRP and increased ESR that we see in psoriasis is also decreased. Acute phase reactant is also decreased. So these are all the functions of TNF alpha, and because of its blockage, we are not being able to have the inflammatory activity seen in our disease, and thus infliximab leads to improvement in inflammatory disorders. Clear? Now, just to revise that TNF alpha is a major molecule. It's a major upstream molecule in the pathomechanism of psoriasis. It has a lot of, you could say, a lot of functions, majorly over endothelial cells, where it increases the adhesion molecule, and because of this adhesion, these circulating inflammatory cells attaches themselves to the endothelium and are migrated from the endothelium to the skin. Okay. So if the adhesion molecules are increased, the migration will also increase. Thereby, infiltration increases. We are talking just about the functions of TNF alpha. It increases vascular endothelial growth factors, and because of that, there's increased angiogenesis, which we see as dilated and tortuous capillaries in biopsy in psoriasis. And more the blood vessels are formed, more the inflammatory cells reach the site. Clear? The effect on macrophage is that pro-inflammatory cytokines and chemokines are released under the action of TNF alpha, and that leads to furthering of the inflammation. On keratinocyte, it increases the pro-inflammatory cytokines, which impact the keratinocyte and increases their proliferation. So more and more keratinocytes are formed. They are formed very quickly. They are not being able to remove properly, and this leads to formation of scales and also skin thickening, which is seen as acanthosis in skin biopsy of psoriasis. On hepatocyte, it leads to formation of more acute phase response, and thus CRP and ESR is increased in psoriasis. So if infliximab blocks TNF alpha, all of these disorders get blocked, and you have decrease in inflammation. Clear? All of these are blocked and inflammation decreases, and you have the therapeutic effect of TNF alpha inhibitors in inflammatory disorders like psoriasis. I hope I'm clear till now. How does infliximab work? Now we'll discuss only the use of infliximab in psoriasis, the regimen that we use in psoriasis, and because all other indications of the at least FDA approved indications are not dermatological, so we'll continue with psoriasis. So we give a 5 milligram per kg infusion, which has to be given over 2 hours. Now remember that 2 hours is minimum. You cannot go lower than that. Usually it is described as 2 to 3 hours. If you want to be safe, 4 hours is a good option. Okay, so 5 milligram per kg infusion over 2 hours. This infusion is given at week 0, at 2nd week, at 6th week. That means 4 weeks after the second dose, and then every 8 weeks. Okay, so you will give the first infusion at day 0. Every box is 5 mg per kg infliximab. Then you wait for 2 weeks, give the second dose of 5 mg per kg, wait for 4 more weeks, give the third dose of infliximab at 5 mg per kg, wait for 8 weeks, give 5 mg per kg infliximab, and subsequently, if the disease activity is still present, you keep on giving infliximab every 8 weeks. Okay, so every 8 weeks you keep on giving 5 milligram per kg infliximab. The duration between 2 doses, let's say 8 weeks, can be reduced to 6 weeks or 4 weeks, depending if you want if the disease is not responding as much, or it responds but relapses very quickly before the next dose. You may play it around a bit and decrease the duration between 2 doses. So that would also help. Okay, so remember that first is after 2 weeks, then 4 weeks, and then after 8 weeks, then subsequently every 8 weeks. Okay, every 8 weekly, you keep on repeating the doses of infliximab. Clear? Now, it has been used in various other disorders, various other skin disorders, but remember that all of them are not FDA approved. But it's good to remember nearly all of these disorders because they can be easily asked in your Viva exam. And there's a lot of overlap between adalimumab extra usages, non-FDA approved usages, and infliximab, both being TNF-alpha inhibitors. So isolated case reports mention the use in hidradenitis suppurativa in sarcoidosis. There are individual case reports, and predominantly the cutaneous sarcoidosis responds very well. Neutrophilic dermatosis like Behçet disease, and it is mentioned that okay, oral ulcers and uveitis, they respond very well to infliximab. Now remember that in adalimumab video we discussed that TNF alpha is very essential for granuloma formation. Okay, so any disorder which leads to formation of granuloma, if the formation of granuloma is because of a non-infective etiology, infliximab can be given. Okay, if it's because of infective etiology, no infliximab. If it is because of non-infective etiology, you may give infliximab. So sarcoidosis is a granulomatous disorder. Other granulomatous disorders like granuloma annulare has been described in getting much improved with infliximab. Now, in neutrophilic dermatosis and pyoderma gangrenosum, the action is because it inhibits the neutrophil migration. Remember that TNF-alpha is responsible for migration of lot of inflammatory cells. So that migration is inhibited, and that is how it helps in neutrophilic dermatosis like Behçet's disease, pyoderma gangrenosum. Similarly, in vasculitis, by decreasing inflammation, decreasing vascular endothelial growth factors, etc. And there have been isolated case reports regarding its use in pityriasis rubra pilaris. Okay, so we have understood about what is infliximab, how it acts, and what are the uses of infliximab, FDA approved, non-FDA approved in dermatology. Now, how do you store infliximab? Infliximab comes in a vial. Okay, I'll show you a picture on subsequent slide. Don't worry, it comes in a vial. The vial has 100 milligram of infliximab. So inside the vial, you will see a white or a slightly yellow cake, a solid, and you need to dilute it, mix it with diluent. Okay, and it is a lyophilized solid, 100 milligram every vial. It is reconstituted by adding 10 ml of sterile water just before using. Remember to dilute to formulate infliximab just before you are going to prepare the infusion and infuse it in the patient. Okay. There are no preservatives in infliximab, so you cannot make an infusion or you dilute it with sterile water and keep it. You have to make sure that just before the infusion, you make infliximab. Okay. So you reconstitute with 10 ml of sterile water and you just before using so that you make the infusion before for that. The storage is for between 2 to 8 degrees Celsius in refrigerator always, but do not freeze. Even if it is kept in freezer, you cannot use it. Keep it in fridge between 2 to 8 degrees Celsius. Do not use after expiration date. That goes without saying. So these are how you are supposed to store the vials. Okay. Okay. So now we know what is infliximab, how to store infliximab vials. Now we'll decide. We have already decided in what all patients you can give infliximab. Now, what are the baseline investigations you have to do before considering infliximab in a patient? And these are the same as what we do for adalimumab. So CBC, LFT, KFT, ESR, CRP. You have to do this to make sure to see how your patient is responding. You measure the decrease in ESR and CRP. Urine routine and microscopy to look at to rule out any infective foci. Monto test has to be done, IGRA if required, chest radiograph for screening for TB. Remember that TNF alpha inhibitors, a good contraindication or a very important contraindication is active or latent tuberculosis, and patient has to be screened before you consider infliximab. Okay, remember that TNF alpha is responsible for granuloma formation, and granulomas restrict TB growth. So if TNF alpha inhibitors are used, granulomas will not be formed and TB will wreak havoc on the body. So rule out any active or latent tuberculosis. Other viral markers like hepatitis B and hepatitis C, HIV, ELISA has to be negative before considering infliximab. Although there have been instances in retropositive patients who have received infliximab for other conditions, but that has to be severely or significantly monitored, it's better you get everything under control before even considering infliximab. Check for any signs of infection. Remember that there are only two black box warning as of now for TNF-alpha inhibitors. One is infection, or in fact severe infection. Severe infection. Other is malignancy. Okay. So rule out any other source of infection. Chest radiograph, urine routine microscopy, TLC, and if you suspect any infection of any particular organ, screen for that at least. Clear? Now administration. Now the patient is ready. We have decided we have to give infliximab. How do you make and give infliximab? Okay. First of all, you need to pre-medicate. Why do you have to pre-medicate? There have been multiple instances of infusion-associated reactions. Roughly, if I remember correctly, roughly around 18%. But we'll discuss that when we will be discussing the side effects of infliximab. So, because of multiple infusion reactions, you need to pre-medicate with steroids, acetaminophen, and one H1 or H2 antihistamine. Okay. So in my institute where I used to where I did my residency, we used to give 100 milligram of hydrocortisone, one ampule of paracetamol, and one ampule of Avil. Okay, so we used to give all of this 30 minutes before starting of infusion to the patient. So we used to pre-medicate with all of these drugs. Then you calculate the total dose. So remember that this is 5 milligram per kg. You can go as high as 10 milligram per kg or as low as 3 milligram per kg. So depending on the body weight, you calculate total dose and then you prepare that many vials. Let's say your patient is of, for example, 70 kgs. Okay, and with 5 mg per kg, it is around 350 milligram infliximab has to be given, and one vial has 100 milligram. So you'll have to actually prepare 1, 2, 3, sorry, 1, 2, 3, and 1 half. So 100, 100, 100, 300, and 50 milligram from this. Discard the rest. So 350 milligram of infliximab has to be prepared in the infusion. So you calculate the dose. Okay, you calculate the dose and you dilute it with 10 ml of sterile water per vial. This is every vial. Then you aspirate that 10 ml and mix it with 250 ml of normal saline to create your infusion. This infusion has to be given over 2 to 3 hours. Okay, do not shake to mix it. It's a lyophilized powder, so if you mix it more, it might lead to complications. Just gently swirl it. Just swirl the vial, it will get mixed up. And after mixing, allow it to stand for 5 minutes and see if everything is properly mixed. To inspect the vial for any particulate matter which is not getting mixed even after diluting with 10 ml of sterile water, or any discoloration prior to administration. Sorry, this has to be intravenous administration. Prior to IV administration. Okay, so remember that it might have slight particles because it's a lyophilized chimeric immunoglobulin. It's a mixture of two different species through the formation of immunoglobulin. So it might have slight particulate matter, but that will be very fine and will be easily dissolved when you allow it to stand for 5 minutes. Okay, dissolve the whole cake in 10 ml of sterile water. Now the vial, as we have already told you, that it doesn't contain any preservatives, so all the unused portion has to be discarded. Begin the infusion within 3 hours of reconstitution and dilution. So the moment you add sterile water to the vial, within 3 hours you need to make the infusion and give the infusion, or at least start the infusion within 3 hours of reconstitution. Clear? So now we have learned how do we prepare an infusion of infliximab and how do we give infliximab. Okay. Now this is the vial of Remicade. Remicade is biological infliximab, and every vial, as we have said, has 100 milligram. Single use. Discard any unused portion. Each vial comes have a enclosed medication guide. So you may at least in Remicade you may have to share that information guide with the patient so that the patient knows what he is receiving and what are the signs to look forward regarding any side effects or any other issues or any questions the patient might have. They've already answered that in medication guide. So give that guide to the patient. Okay, so now you're starting infusion, patient receiving infusion, everything is hunky dory. Okay, now it is said that at 12 weeks of giving infliximab, that means 12 weeks means 0, 2, 6 week and 8 week. So roughly at the third to fourth dose, if there is no significant change in PASI. Now PASI is supposed to be said that PASI 75 would be, let's say 48% approximate patients will reach PASI 75 at 12 weeks, and I think around 15 to 20% will have PASI 90 at 12 weeks. If there is not a similar kind of improvement at the end of 12 weeks, you might consider decreasing the duration between subsequent doses of infliximab. And if that also is not leading to further benefit, you might have to consider discontinuing infliximab and look for other therapeutic options. Okay. Now, so we know how to give infusions. We have given infusion. Now we'll study about contraindication and side effects of infliximab. Remember that infections is a black box warning for infliximab. The infection rate has found to be around 36% with infliximab as compared to 25% with placebo. It is significantly different, so we need to keep an eye out. We have to keep us active to find out if the patient is showing any signs of infection. Infections such as pneumonia, cellulitis, abscess, skin ulceration, sepsis, bacterial infection have been reported, so keep a lookout for them. Opportunistic infection like various deep fungal infection like aspergillosis, blastomycosis, candidiasis, pneumocystosis, histoplasmosis has been significantly seen in patient receiving uh, infliximab. Tuberculosis again becomes a very important opportunistic infection, especially in our country, where patients might have a history of TB contact, history of active tuberculosis treated with ADT, or they have latent tuberculosis, which might get reactivated with infliximab. So remember, if any patient is receiving any TNF alpha inhibitor and shows any sign of new infection, you need to properly screen. If there's any infection, let's say any UTI or URTI, so it's better to get that treated and then start infliximab. Do not combine with anakinra or abatacept or any other TNF alpha inhibitors because it increases the chances of infection. Okay, it increases the chances of infection. So do not combine two different TNF alpha inhibitors together. On what all patients you should not give infliximab if they have any kind of active infection. Okay, any kind of localized infection. Let's say if they have a the psoriatic plaques have gotten infected, or let's say you have hidradenitis suppurativa and you want to give infliximab. Better to give it under cover of first start an antibiotic, and under the cover of antibiotics like doxycycline, azithromycin, and others. You may consider giving infliximab, but be very cautious. Elderly patients, because they have decreased ability to fight other infections, so not to give. Patients who have other comorbid conditions like diabetes mellitus, which increases or predisposes them to get other infections, it's better not to consult or consider infliximab in those kind of patients. Patients who are taking concomitant immunosuppressant like corticosteroids or methotrexate, remember that a lot of time your patients would have been already taking a lot of immunosuppressants before even being considered for any kind of biologics. So it's better to keep that in mind if you want to continue those other immunosuppressants along with infliximab or not. Additionally, infliximab makes autoantibodies, and for to prevent that autoantibodies, methotrexate or even a low dose methotrexate is always more or less always given with infliximab. So remember that addition of methotrexate will lead to decreased autoantibodies but might predispose the patient for more infections and malignancies. So we'll discuss that only a little bit when we'll be discussing methotrexate and infliximab. Clear? Now, tuberculosis. Literature mentions that the cutoff for tuberculosis for Monto test for tuberculosis is 5 millimeter. However, the cutoff might be raised in country like India where the prevalence is a lot higher. So if it is less than 5 millimeter, it's somewhat safer in country with infliximab. More than 5 millimeter, then do other investigation like chest X-ray and IGRA. Okay, if there's any other causes of immunosuppression, let's say diabetes mellitus, HIV, okay, any other immunosuppressive drugs they are taking, okay. Consider TB if any new infection occurs. Any new infection in any patient receiving any TNF-alpha inhibitors, consider tuberculosis, deep fungal infection also. We might not see them that commonly, but consider them if the patient is receiving TNF-alpha. Treat the TB first before trying any kind of infliximab or TNF-alpha inhibitors. And if you find a focus of TB, treat TB first, especially if the prior treatment is inadequate or doubtful. So if the patient says that yes, I was found to have TB, let's say 10 years back, and I could not complete the treatment. I took treatment for 2 months. It's better to give the complete treatment again and treat TB first. If you find evidence of tuberculosis on investigation, treat it first and then consider infliximab. Now, this flow chart is the repeat flow chart from the Adalimumab video. So, we'll just discuss it very shortly. I will also give the link to access this individual paper in the description. So, if you want to read, I highly suggest you to go through this paper. Now, assess the patient in his patient history for any TB exposure, signs, symptoms, get a chest X-ray done, and see if the patient is having any focus of tuberculosis. If the focus is present, assess whether the active TB exists or not, or if it is just latent. If active TB is there, you have to treat. No other choice. If active TB is not there, you look for latent tuberculosis and you give preventive therapy with isoniazid for 6 months or isoniazid rifampicin combination 4 months. So you give the treatment for preventive therapy for tuberculosis for at least 4 weeks, and then you give anti-TNF-alpha therapy. Clear? We are clear from here, and this is when you find a focus of TB. If you don't find a focus for TB, get a Monto test done. If the Monto test done is more than 15 millimeter, you start tuberculosis therapy. If it is between 10 to 15, do IGRA. If IGRA is positive, you start TB treatment. If IGRA is negative, you start TNF-alpha treatment. Clear? If it is less than 10, and remember for infliximab, the cutoff which has been described in literature is 5 millimeter, you see other risk factors are present or not. If they are present, get an IGRA done. If positive, treat for TB. If negative, give TNF-alpha. If the risk factors are not present, then give TNF-alpha inhibitor therapy. Okay, clear? If you're not clear, go back to the Adalimumab video and see. We have discussed this flowchart in much detail in that, and you'll be able to easily find logic in what all tests to done, when tests to be done, when to be done, when they have to be done, and what are the and how to proceed regarding different interpretation of different tests. Okay. Now, malignancy is also a black box warning for infliximab, especially in patients where the therapy is initiated before they are 18 years of age, or as the papers mention, when the first dose is received in patients who are less than 18 years of age, the chances of malignancy increases. Okay, remember that infliximab and all of these studies come from non-dermatological uses like pediatric Crohn's disease, etc. So these data comes from those kind of studies. Malignancies like lymphomas, both Hodgkin and non-Hodgkin lymphoma have been reported with the use of TNF-alpha inhibitors and infliximab. It says that median of 30 months, ranging from 1 to 84 months after the first dose. This is the you could say the onset of malignancy, or you could see that clinical feature of malignancy develop within this time. The risk of malignancy significantly increases if any concomitant immunosuppressant like steroids or methotrexate is also being taken. So keep that in mind too. Now, lymphomas are 3 times higher than expected in general population when the patient is taking TNF-alpha inhibitor. Now remember that even if TNF-alpha inhibitor is not being given, patients who have rheumatoid arthritis already have a higher risk of developing lymphoma. In some of the studies, it is described as 2 times the general population. So even the disease itself can cause or lead to malignancies. So we have to keep that in mind, whether it's because of the disease or whether it's because of the drug. If it's because of drug, you have to stop the drug. Lymphomas like acute and chronic leukemias, it's leukemia, not lymphoma, but these have also malignancies have been also described. Other malignancies like hepatosplenic T-cell lymphoma has been described, especially in patients who receive azathioprine or 6-month captopril concomitantly. So, receiving azathioprine with TNF-alpha inhibitor increases the chances of patient to develop hepatosplenic T-cell lymphoma. That has to be kept in mind. There have been case reports of melanoma, non-melanoma skin cancers like SCCs, and Merkel cell carcinoma also with patients who are receiving TNF-alpha inhibitor. So now you have a good 4 or 5 names of malignancies associated with patients who are taking TNF-alpha inhibitors, particularly infliximab. Okay, these include nearly all of the malignancies which are reported with adalimumab. So you'll see how different TNF-alpha inhibitors have nearly same list of side effects, including malignancies and infections. Now, other side effects, as we have already mentioned, that infusion reactions are very common. They are seen in about 18% of population. 18% of patients who are receiving infliximab can have infusion reactions. Okay, and a good way to prevent this kind of infusion reaction is to pre-medicate. So we have already described how to pre-medicate. You give steroids, H1, H2 antihistamines, and acetaminophen to pre-medicate. Okay. Now, autoantibodies. Remember that infliximab is a chimeric molecule. Chimeric molecule, that means half of them, 25% of it comes from mouse. So it can lead to a lot of autoantibodies, and in literature is about 10% of the patients will develop autoantibodies. And remember that because of autoantibodies, the efficacy might subsequently decrease. The efficacy of infliximab might decrease on subsequent infusion. Okay. Now, the assay which is used to find out the level of autoantibodies autoantibodies in patients with infliximab, somehow the serum infliximab, the infliximab which is active and free in the serum, interface with the assay. So if you are using any kind of assay to calculate how much autoantibodies are there in the patient, it might lead to certain underestimation. Okay, so the report, or if you want to measure the amount of autoantibodies, the number might be low. It might be a lot more in the patient's body. Okay. Other antibodies like ANA and anti-dsDNA has also been described, which may further lead to a lupus-like illness. Remember that we had discussed lupus-like illness in adalimumab also. So TNF-alpha inhibitors do have a chance of developing other antibodies like ANA and dsDNA to cause lupus-like illness. ANA has been found in as high as 50% of patients as compared to 20% with placebo, and anti-dsDNA has been found in 20% of patients as compared to 0% in placebo. Other reactions like hypersensitivity, including urticaria, dyspnea, hypertension within the 2 hours of infusion, has found to be associated with infliximab. But at least this can be uh, prevented by pre-medication, and it is somewhat directly proportional to the amount of autoantibodies the patient has. Hepatitis B reactivation has been mentioned. Hepatotoxicity infliximab can lead to acute liver failure, jaundice, hepatitis, cholestasis, and the change in ALT, or in other words, the SGPT is usually more as compared to AST or OT. Okay, this hepatotoxicity in initial stages is symptomatic. That means only the reports will show a deviation of these enzymes. So it will show only transaminitis, and it is also reversible. So the moment you stop infliximab, the enzymes tend to return back to normal. Now, congestive heart failure. NYHA class 2-3 is a relative contraindication for infliximab, only to be given in life-saving conditions. The TNF-alpha inhibitors, nearly all TNF-alpha inhibitors can precipitate congestive heart failure, so the patient has to receive the infusion under cardiac monitoring. There has to be a good history taking to find out any uh, clinical signs or symptoms on history of congestive heart failure, any history of heart disease in the family. Patient has to have let's say an ECG, good cardiac monitoring during infusion, so that any other causes of congestive heart failure can be previously, before starting infusion, can be looked into. Now, demyelinating disease have also been described as an absolute contraindication, or you could say side effect of TNF-alpha inhibitors. This is more important with adalimumab, but in infliximab also it has been found that it may cause demyelinating disorders. So, demyelinating disorders like central demyelinating disorders causing cerebral dementia, or peripheral demyelinating disorders like Guillain-Barré syndrome have also been reported with infliximab. Cytopenias like leukopenias, lymphopenias, uh, thrombocytopenias, anemias have all been reported with infliximab. Okay. Vaccination. Remember that if pediatric patients are being treated with infliximab, it is FDA approved in pediatric ulcerative colitis and pediatric Crohn's disease. So remember that, of course, we will not be using it that commonly in pediatric population for for skin diseases. But if you have a pediatric patient, it's better that they have to be brought up to date with all the immunizations that they are supposed to receive. Patient on infliximab may receive concurrent vaccinations, but these vaccinations have to be either dead or attenuated. Okay, it should be dead, or sorry, either they should be dead or subunit vaccinations. Okay, no live vaccines are prescribed, or you could say recommended, while the patient is receiving infliximab. Otherwise, the pathogen may get reactivated after injection. Okay, so no live vaccines in infliximab. So any kind of therapeutic infectious agents cannot be given concurrently with infliximab. Now let's discuss a little bit about using methotrexate along with infliximab. So remember that low-dose methotrexate prevents autoantibodies against infliximab, and autoantibodies are those antibodies which will decrease the efficacy. So if you combine infliximab with methotrexate, the autoantibodies are not more formed that much, and they are not able to decrease the level of infliximab or the efficacy of infliximab. So it's always beneficial to combine them. Remember that FDA approval for rheumatoid arthritis for infliximab is only to be used with methotrexate, not without that. The dosage that is routinely used is 7.5 mg per week. Methotrexate will have an additional effect on treating psoriasis and psoriatic arthritis along with preventing autoantibodies to infliximab. But remember that patients might be receiving methotrexate prior to giving infliximab, so total cumulative dose of methotrexate should be kept in mind, and the additional side effects of methotrexate should be kept in mind. Along with that, if you add one more immunosuppression to infliximab, it will lead to increased immunosuppression. So infection risk also increases, and it also increases the malignancy risk. So keep that in mind when you are, let's say, combining two different immunosuppressants, especially methotrexate with infliximab. Now, this good article I found about using methotrexate with infliximab, and it says that when the dosage of infliximab is low, let's say 1 milligram per kg, you can find that the white circles are infliximab given without methotrexate. The doses return back to as low as baseline because of autoantibodies. Okay, but if you give with methotrexate, that means the black one which are infliximab with methotrexate, the level somewhat remains above baseline. Okay, and it doesn't tend to touch baseline. But as we increase the doses, the level still doesn't touch the baseline and remains above baseline. Okay, so that means using increased dose of infliximab does not show that much autoantibodies, and the and the efficacy of infliximab, or let's say the circulating active infliximab, remains more or less the same. Okay, so you may not have to give that higher dose of methotrexate to prevent any autoantibody formation. As low as 7.5 milligram per week will also work. Now remember that giving with methotrexate, it inhibits autoantibody formation, but it also increases the infection risk. It increases the malignancy risk. Okay, also increases immunosuppression. TNF-alpha inhibitors are not supposed to be combined with each other, also with anakinra or abatacept, because it shows in few studies it doesn't show any added benefit. Also, it increases all the side effects. So, two different TNF-alpha inhibitors should not be combined together. Now, it should not be combined with tocilizumab because it may increase the level of immunosuppression that will lead to a lot of side effects. So, no combination with tocilizumab. Now, this pregnancy is somewhat similar to adalimumab. Not much data is present. The new category says it as low risk. The older category is category B. Now, infliximab is transferred through placenta and has been found till 6 months postpartum. That is in the baby. Okay, so even after 6 months post birth, the serum does show infliximab, which have been transferred through the placenta. Now, remember that these biologicals are IgG molecules, and IgG does cross placenta. That's how you have transfer of maternal antibodies from mother to the child, and infliximab is seen as long as 6 months postpartum in the baby's circulation. Whether the presence of infliximab has any kind of issues or any problems in the baby, whether it causes any problems, that is yet to be seen because not much studies have been done. But it's better to avoid live vaccination till the level of infliximab goes down or to zero. So you have to prevent any live vaccination in the baby. Okay. There's not much data in lactation, but it's better to avoid because there is always a theoretical transmission of these molecules to the baby. And unlike adalimumab, in adalimumab we mentioned that even if it goes inside the GI tract of the baby, it might get destroyed by all the stomach acids, but the localized action, that means action on the intestines, has not been studied as well. So it's better to avoid lactation, but remember that in multiple countries and scenarios, lactation becomes a very important part for the child's health. So you have to weigh in the risk factors, and you might have to continue lactation even with infliximab. Clear? So with that, we'll stop this presentation today, and we have discussed infliximab in somewhat detail. At least after this presentation, you'll be able to answer regular questions or normal questions about infliximab, which you may be asked in Viva. And additionally, you'll be much more comfortable in using infliximab. Remember that infliximab is limited by it being an IV infusion, so you need to hospitalize the patient, but the efficacy is found to be somewhat similar to adalimumab and other drugs uh, in chronic plaque psoriasis. So you may consider what all treatments to be given depending on the individual patient profile. So with that, we'll stop our discussion on infliximab. If you have any issues, any doubts, just email me on my email ID, or you just comment your doubts or suggestion in just below the video, and we'll address that. If you have any other question that has been asked regarding infliximab in your vivas or in your postings, feel free to add that in the comments so that I'll be able to find the answers, and we'll be much the wiser regarding this drug. Okay, so we'll meet again next week with another TNF alpha inhibitor, and slowly, one drug per week, we'll be able to understand these biologicals in somewhat clearer manner. And if you have any doubts, go back and see the video on psoriasis pathogenesis, and you'll be able to understand how these biologicals are working. And if you know how a drug works, you'll be easily able to understand its side effects. Okay, so remember to go through the previous videos, and if you have any doubts, just write to me, email me, or message me, whatever you deem comfortable. With that, I'll switch off the presentation, and adios and good night.